You see a child, acute onset hemiplegia, facial droop, can't speak clearly. Your brain goes, stroke. And you'd be right to think that. But here's the thing, you might also be wrong. Because 11 other conditions can look exactly like stroke in a child. And getting it wrong means the wrong treatment, delayed diagnosis, and a very different outcome. Welcome to the final part of the Pediatric Stroke Series on Nurture and Neurology. Today we are talking about stroke mimics, when it looks like a stroke but isn't. If you've been following this series, thank you, genuinely. We've covered arterial ischemic stroke, CSVT, hemorrhagic stroke, and management. Today, we close it out with a differential diagnosis, the conditions that masquerade as stroke and demand we keep our clinical eyes wide open. The golden rule we start with, any acute focal neurologic deficit in a child is a stroke until proven otherwise. You image first, you think second, but you also need to know what else could be on the table, because some mimics need their own urgent treatment. Let's get into it. So what are these mimics? There are 11 I want you to know. Migraine, seizure with Todd Paresis, CNS infection, demyelination, hypoglycemia, hypertensive encephalopathy, specifically PRES, inborn errors metabolism, vestibulopathy, and ataxia, channelopathies, alternating hemiplegia of childhood, and functional neurological disorders. Each one has a clinical signature. Let's go through them one by one. Starting with migraine, probably the most common mimic you'll encounter. The key word with migraine is march. The neurological symptoms evolve slowly. Weakness or sensory disturbance spreading across the body over minutes, not arriving at once like stroke. The aura lasts between 5 and 60 minutes and then completely resolves. Headache usually follows. But here's where it gets tricky. There are acephalic migraine subtypes that happen without headache. Familial hemiplegic migraine, basilar migraine, migraine aura without headache. These can genuinely look like stroke. And then there's RCVS, reversible cerebral vasoconstriction syndrome. Patient with migraine history or on SSRI or triptans who present with thunderclap headache and focal deficits, MRI is your friend here. It distinguishes RCVS from CNS vasculitis. On imaging, migraine is typically normal. Migrainous infarction does exist, but it is rare. Next, we have seizure with Todd Paresis. Todd Paresis is a postictal focal neurological deficit, hemiparesis, aphasia, visual disturbance that typically resolves within hours of the seizure. The classic picture is a child who's been having a generalized or focal motor seizure and then wakes up with a weak arm or leg. That's reassuring because it resolves. But here's the trap everyone misses. Stroke in children often presents with seizures. So when you see a child who has had a focal seizure and has a persisting focal deficit, you cannot assume it's just Todd Paresis. Image urgently. Even rarer, focal seizures can present with purely negative symptoms, just hemiparesis, no visible jerking. You'd never know a seizure was happening. EEG and imaging both are needed. The bottom line, don't let seizure lull you into missing stroke. Moving on, infection and demyelination. For CNS infections, bacterial meningitis, herpes encephalitis, brain abscess. The differentiating feature is the trajectory. Gradual onset, fever, encephalopathy, meningismus. These are not the sudden focal deficits of stroke. But, and this is important, children with bacterial meningitis are at genuine risk of both arterial ischemic stroke and cerebral synovenous thrombosis. So infection doesn't always rule out coexisting stroke. Demyelination, ADEM, clinically isolated syndrome, multiple sclerosis. Again, gradual onset, hours to days, not seconds to minutes. Multifocal deficits, optic neuritis. Encephalopathy in ADEM makes stroke less likely. Imaging shows multifocal lesions in characteristic locations, pericallosal ovoid lesions in MS, patchy bilateral edema lesions, and crucially, less likely to show restricted diffusion than a true infarct. Now the metabolic mimics. Two biggies. Hypoglycemia. Don't forget this one, especially if there is a history of insulin-dependent diabetes, steroid withdrawal, or a child on ketogenic diet. It can produce focal deficits that genuinely look stroke-like. Imaging is bilateral symmetric, posterior dominant, and you may see restricted diffusion. Check the glucose always. PRES, posterior reversible leukoencephalopathy syndrome. Child with hypertension, often a sudden spike in blood pressure. They come with bilateral visual disturbance, seizures, encephalopathy. Imaging is beautiful. Bilateral posterior patchy lesions involving grey and white matter, and crucially, usually no restricted diffusion. That's your tell. It's posterior and bilateral, not following an arterial territory. Treat the blood pressure. Now, one of my favorite topics, inborn error of metabolism, and specifically MELAS. MELAS stand for mitochondrial myopathy, encephalopathy, lactic acidosis, and stroke-like episodes. And it's exactly what it sounds like. These kids have stroke-like episodes that aren't vascular at all. They are metabolic. The red flag for MELAS are history of developmental regression, sensory neural deafness, MRI lesions that are posterior and bilateral, and crucially, they don't respect vascular territories. A true stroke follows an artery, MELAS doesn't, and MR spectroscopy shows that high lactate peak. Now, important nuance. Kids with Fabry disease, hyperhomocystinemia, and homocystinuria can get true ischemic stroke. So, not all metabolic conditions are mimic. The bottom line, young child, regression, deafness, non-vascular territory lesions, raised lactate, think mitochondrial disease. Quick ones now. Vestibulopathy, vertigo, imbalance, no limb weakness, no cranial nerve deficits beyond vestibular. Bedside hints exam helps distinguish peripheral from central. MRI is normal. Differentials include acute vestibular neuronopathy, viral labyrinthitis, benign paroxysmal vertigo of childhood. Channelopathies, an expanding group of ion channel mutations presenting with sudden focal deficits. Not a single anatomic lesion. More episodic and progressive. Strong family history raises suspicion. Normal MRI. Genetic testing confirms. Think episodic ataxias, familial hemiplegic migraine. Now a special one, alternating hemiplegia of childhood or AHC. This one is remarkable. These children, typically presenting in late infancy, have episodes of hemiplegia that alternate between left and right sides. The episodes last minutes to weeks and then resolve spontaneously. Chorioathetosis and dystonic movements are often present in the hemiparetic limb. There is one absolutely pathognomonic feature. The hemiplegia resolves with sleep and then recurs on awakening. If we hear that history, that's AHC until proven otherwise. They also get autonomic features, flushing, pallor of skin, and almost universally progressive intellectual disability over time. It's linked to ATP1A3 gene variants. That's your exam fact. But critically, always image these children. Get MRI and MRA. You must exclude Moya-Moya disease before you can comfortably diagnose AHC. And finally, functional neurologic disorder or FND, previously called conversion disorder. This is not a diagnosis of exclusion in a pejorative sense. It has positive clinical signs and is not a last resort. What to look for? Recent psychosocial stressor, symptoms that don't localize anatomically, inconsistency in examination findings across the assessment, and the Hoover sign. When examining for supposed lower limb weakness, if the examiner holds the heel of the unaffected leg and asks the patient to raise the affected leg, the unaffected heel will push down involuntarily. That's a positive Hoover sign and it's a functional clue. MRI is normal, But don't forget that FND and organic disease can coexist. Do the workup properly. So here's your at a glance summary. I've put this in a table so you can screenshot it, save it, use it for your exams. 11 conditions, their clinical key clue and the imaging finding. Pause here if you need to. Let me leave you with the 6 things I want you to walk away with today. 1. Time is brain. Treat every acute focal deficit as stroke until imaging says otherwise. Go fast. 2. Migraine, seizure and metabolic causes are your most common mimics in pediatrics. 3. Normal MRI does not rule out stroke. Early DWI can be falsely negative. Repeat imaging if high suspicion. 4. MELAS lesions are bilateral, non-vascular territory and lactate is elevated on MR spectroscopy. 5. AHC resolves with sleep. Get MRA to exclude moya. 6. Functional disorders have positive signs. Hoover sign, inconsistency. They are real diagnosis. That's the Pediatric Stroke Series. All 5 parts done. Thank you so much for being a part of this learning journey. If this helped you, please share it with a colleague who's prepping for exams or just starting in pediatrics. Like and subscribe if you'd like to see more content like this. And drop me a comment. I want to know which part of the stroke series was most useful for you. See you in the next video. This is Nurture Neurology, where brain health meets real life.